Thank you, Simon, and the organizing committee for this opportunity for me to present. I have no specific disclosure. So, while watchful waiting in asymptomatic severe MR is often done, how does one select patients to avoid potential problem? And this is really the crux of the question: is how do we prevent patients from getting worse or having event? And is waiting with severe mitral insufficiency that is relatively asymptomatic something that is dangerous or potentially risky? And as you might imagine, the data around that is not that common. And this is based a little bit on some historical data, but this is a New England Journal paper published many years ago, I think in 2005, that looked at quantitative determinants of outcome in asymptomatic mitral regurgitation patients, just to show that the curves here, the curve with the worst event-free survival, and this is death from any cardiovascular cause in severe MR, in patients that obviously with worsening severity that were asymptomatic and followed expectantly, you can see that over time these patients experience excess morbidity and mortality. And so this would suggest that obviously this is not benign. So before I discuss the type of patient that really I want to focus on today, is I need to define first primary versus secondary mitral insufficiency. And today we're really talking about primary mitral valve insufficiency, which is really a structural valve problem. And this is how Carpentier classifies that as a type 2 leaflet prolapse. And this is very different than type 1, which is really a dilated annulus in which the leaflets don't meet together, or a type 3, which is a restricted leaflet based on a ventricle that is dilated, or a wall of the ventricle that doesn't work properly and pulls on that leaflet, all of which result in mitral insufficiency, but by different mechanism. So today we're going to focus really on leaflet prolapse, one versus the other, or both of them prolapsing. And this is based on the annular plane as the reference. So primary mitral insufficiency in asymptomatic patient with lower EF or LV dilatation is an indication for intervention, and this is the recently published American Heart Association guidelines focusing on primary MR. So clearly, if you have a ventricle that is depressed or starting to lose its function or become dilated, this is a clear indication. This is not really the group of patients I want to talk about today. What I really want to talk about is the asymptomatic patients with severe mitral insufficiency and normal systolic function. And in those patients, it is quoted to be reasonable to consider repair. One, the likelihood of a successful repair without residual MR is estimated at better than 95% with a low mortality for the procedure and should be performed at a primary valve center. So this is really important. And this is really the kind of patient here that we should be thinking about. So what do we mean by, likelihood of repair? And this is what I'll spend some time discussing and explaining. So a likelihood of repair, when we think that there's more than 90 or 95% chance of repair, we're really focusing on posterior leaflet prolapse, and we're focusing on myxomatous pathology. The problem with myxomatous pathology is it's an evolving disease in the sense that as patients have myxomatous changes, if you wait long enough, these myxomatous changes do progress. And so, for example, the classic sort of, just a little cord rupture in the posterior, this is a P1, P2, and P3 scallops, a little cord rupture in the P2 here with a relatively normal looking leaflet is actually called fibroelastic deficiency, and it is in the spectrum of myxomatous disease. This is a relatively straightforward problem to fix. And the same here is a much larger P2 scallop that is affected, and eventually you get to the point where P1, P2, and P3 are potentially affected, or true Barlow's that infects A1, A2, A3, P1, P2, P3. Essentially all segments are affected with this myxomatous changes, which are prominent, thickened, large leaflets that look sort of bulging and affecting the valve. And so clearly for us, for likelihood of repair is an isolated segment, whether it's in P1, P2, or P3, a good anterior leaflet, because you need a good anterior leaflet to be the functional part of the valve, and a posterior leaflet that's not too prominent. As it becomes very prominent, there's a lot more things you need to do to it to try to get a coaptation on that valve. So I wanted to show this example here. This is a classic normal looking anterior leaflet. You can see here the annular plane is here. That anterior leaflet never goes above the anterior plane, and that posterior leaflet is not very long, which is great, but there's a part of the chordae that are prolapsing above, and that creates that anterior directed jet of mitral insufficiency. This is really a classic type of patient of which you would expect a very high likelihood of repair. Some of the other things that we tend to look at is I want an anterior leaflet that's long enough to cover the orifice. So if you have a very short anterior leaflet, you might not be able to repair that valve well. You also don't want a very large bulge of the septum here, because you might be tempted, or you might push that coaptation to a little bit more anteriorly, and then you'd get the cords dragged into the LVOT and have systolic anterior motion of the leaflet and have SAM and have still MR due to that from a functional point of view. So this is the kind of patient you'd expect a repair, and this is a repair. You can see the annuloplasty ring. You can see that most of the work is done now by the anterior leaflet, and actually that patient also had an aortic valve replacement for a bicuspid aortic valve. So this is a classic patient in which the likelihood of repair would be high. I obviously chose this example. There was something else obviously to do here, but just from an echo purposes. So what about less likely to repair? Well, less likely to repair, there are still lots of patients in which it's possible to repair. So isolated anterior pathology can be repairable, again, depending on what it is, and if it's localized to one area versus multiple area, and there's a variety of techniques we can use, but we cannot say generally at more than 90 or 95% chance of repair. Some bileaflet pathology also can be pretty straightforward, but again, it depends. You need to look at it. Some type 1 here is not, this is a functional problem we're not going to talk about today. And obviously less likely to repair is when there's any calcification of the leaflets. Calcification of the annulus is a little bit easier to deal with, but the leaflets themselves can be quite challenging if it becomes calcified, because I can't grab them, I can't suture to them, I can't perform some of the things I would normally do. And a true Barlow's disease would also be difficult. And finally, severe LV dysfunction in a setting of functional either type 1 or type 3 can be quite challenging. But again, this is not a primary problem, this is a secondary mitral insufficiency problem. So I wanted to show this echo here because it illustrates severe mitral insufficiency, but in this case you have a very prominent posterior leaflet. You can see how large that posterior leaflet is. There's obviously uber amount of mitral insufficiency, and that anterior leaflet also looks pretty normal actually. It looks long, it looks feasible. The only problem is that large amount of tissue posteriorly. It looks very Barlow's-like, and if you look here, here's another look at the amount of posterior tissue there is, and that can be challenging. And so you need some techniques to be able to resect some of that Barlow's tissue to be able to make use of the anterior leaflet that still looks pretty reasonable. So a little bit more difficult to repair here. And so this is the repair that we had in this particular patient. You can see that the valve here looks good, and we make use of most of the anterior leaflet and a large ring. You can see here the annuloplasty ring. So a little more challenging. If I were to see that echo, I would not be able to tell you this is a 95% chance of repairing that valve. Even if I have relative confidence that we can repair reliably that valve, I think there's a little bit of risk there. And this was a young lady in her 50s. I think you really want to push pretty hard in fixing this valve, because a prosthetic valve is not without its issue for that particular patient. So what are the surgical principles of when we think of repairing a valve? Well, this is the view that I see of the valve. If it's a very small segment, you can think of resecting that segment, or alternatively, you can add some cords to these segments. And so you might actually resect, or you might add some cords. As you can see here, you would measure the cords either by echo or physically, and use Gore-Tex to replace the cords. There's still some debate of whether or not you should replace cords versus resecting, a combination of both. I tend to use a little bit of both depending on things. And finally, all of us tend to complete the repair with an annuloplasty ring. Whether you use a half ring like this or a full ring depends on preferences and some theoretical advantages of one or the other. Generally, I would tend to use a full ring. What's really important is that you start the ring at the trigone, which is not exactly at the commissure. It is really on the fibroskeleton, and the same thing here on this valve. And you can see the anterior leaflet is what allows the valve to close and to get coaptation. the posterior leaflet is really, when it's repaired, is really used as a buttress to which the anterior leaflet gets to. So the modern treatment of mitral valve insufficiency in the setting of primary, whether you use cords or resection, should have a very low surgical risk of under 1% the majority of the time, and a long-term survival, certainly at 5 years, that should be well above 90%. So these patients should do well. These are the kinds of patients, this is close to surgical cure as I get without really getting to surgical cure. So at the New Brunswick Heart Center, we perform on average about 70 or so mitral intervention a year. Those 70 or so mitral intervention obviously includes combination procedure and isolated procedure. And you can see here that we repair about 50% of those patients, and we repair more than 70% of the degenerative patients. So there's still some rheumatic disease here, some other associated valve disease with previous prosthesis and or ischemic disease. So this is a mishmash of all those. The numbers are around 90 per million. So Nova Scotia would be around 90 to 100 mitral valve intervention a year would be what you would expect. And so we tend to approach isolated mitral insufficiency in a minimally invasive approach. This is a small thoracotomy in which you have some different ports that you use, and the basis for most of our mitral interventions are done that way. And essentially, out of the mitral valve volume that you saw in the previous, it's about half of that volume is minimally invasively. Obviously not all of it, because some of the procedures are obviously CABG and mitral or aortic valve and mitral. There are a combination of different things. And we can do through this incision mitral and tricuspid interventions, as well as MACE procedure. This is again the approach through a small incision, plus or minus the camera, and then you can enter the heart that way. You obviously cannulate the blood vessels in the groin to go on bypass to allow you to do the procedure. And there's been numerous case series illustrating the success of such an approach and how useful it is and how safe it is in comparison to standard through sternotomy. And if you actually compare via meta-analysis, there is a trend towards favoring minimally invasive approach versus conventional, but this does not reach significance. So what are the advantages theoretically of minimally invasive approach? And these are obviously retrospective studies. There's only one randomized study that I know of, and it was a small sample size of 70 only. So the proposed advantage is obviously improve cosmesis, patient benefit from that point of view. Improve recovery time. There is a little bit of shorter duration of ICU and length of stay, but most of the improvement are really at several weeks after the intervention. Faster return to daily activity in the workforce, that is clear. Less blood loss and transfusion. And this obviously gives us an alternative approach for redo cases through a right thoracotomy. So who is then the ideal patient for asymptomatic patient for early mitral valve repair? Well, I think as we pointed out before, early likelihood or high likelihood of repair is key, and you need a TE to determine that. I think young patient in whom the benefit will have the most impact are really the ones you want to focus on. So age less than 70 is really what you aim for. Obviously other patients you can consider, but these are the patients that are going to have the lifelong benefit of decades potentially of benefit, is really the ones you want to be considering the most. Few comorbidities, so that obviously the risk of the intervention is low because they are asymptomatic. If they have multiple comorbidities or issues, then obviously the risk of the intervention potentially outweighs the benefit. And no concomitant valvular or coronary disease is obviously clear, because then you would obviously be intervening for other reasons and may not be able to do this minimally invasively also. So in summary, I think severe asymptomatic mitral valve insufficiency can be associated with excess morbidity and mortality. So therefore, there are clearly some patients we should be considering for intervention. And mitral valve repair in selected patients can be performed at low and very low risk. The key is really patient selection based on echo findings, discussion with a surgeon, his cardiologist, and discussion with the patient in terms of preferences, risks, and all. Minimally invasive mitral valve should be considered in most isolated mitral valve cases. Thank you very much, and I'd be happy to entertain any question. Here's a beautiful picture of St. John, New Brunswick at the New Brunswick Heart Center, and my colleague Ansar Hassan obviously performing some of these procedures also. Thank you.